Greetings from India. Thank you very much for giving us an opportunity to present and participate in this International Laboratory Medicine Case Contest. I am Dr. Karuna Ramesh Kumar, the pathologist, and my colleague is Dr. Anne Agnes Matthew, the pediatric neurologist. We both worked together in Rainbow Children's Hospital, during which time this case happened. At present, I am engaged in Mitra Multi-Speciality Hospital also in Bangalore, India. The case we are going to discuss is on variance of blood and CSF glucose levels as a clue to rare gluten deficiency type 1 syndrome. As you are all aware, the blood-brain barrier plays an important role in providing the nutrients to the brain. The cerebrospinal fluid analysis plays an important role in the diagnosis in children with neurologic disorders. It is important to correlate with clinical features and results of other investigations to arrive at the diagnosis. Coming to the clinical history of this patient, a 12-year-old boy presented to pediatric neurology department with cognitive deficits, myoclonus, and dystonia of both upper limbs. He was born of non-consanguineous marriage. Baseline investigations and cerebrospinal fluid analysis were done. The salient investigations included ammonia, which was 67 micromoles per liter, creatine phosphokinase, thyroid stimulating hormone, liver function test, and complete hemogram, which were done, were within normal limits. The blood glucose level was 89 mg per deciliter. The CSF analysis showed protein 13 grams per deciliter, glucose 39 mg per deciliter, and lactate 7.9 mg per deciliter. In view of the clinical features and low CSF glucose compared to blood glucose levels, glucose transporter deficiency, gluten deficiency type 1 was suspected. To explain about the blood-brain barrier and the SLC2A1 gluten transporter, the figure is given here. As you all see from the figure, there are different transporters: ABC transporters, transporters for ions, and transporters for peptides, and transporters for nutrients. The nutrients are ketones and glucose. Now the GLUT1 transporter encoded by the SCL2A1 gene is the main transporter for glucose, and mutation in this gene can lead to GLUT1 deficiency syndrome. This condition can be treated with ketogenic diet that allows the brain to primarily use ketones as an alternative source of energy. Ketones are primarily transported through the MCT1 transporter, which is encoded by another gene, which is SLC16A1 gene. So in this patient, SLC2A1 gene sequencing was done to confirm the diagnosis. Heterozygous variant of autosomal dominant gluten deficiency syndrome type 1 was confirmed. The patient was counseled and put on ketogenic diet. He improved and is on follow-up. To explain about a ketogenic diet primarily consists of high fats, moderate proteins, and very low carbohydrates. The dietary macronutrients are divided into approximately 55% to 60% fat, 30% to 35% protein, and 5% to 10% carbohydrates. The term ketogenic diet describes to any diet therapy in which the dietary composition brings about a ketogenic stage of metabolism. The classic ketogenic diet consists of long-chain triglycerides, usually applied as a ratio of fat to non-fat, protein and carbohydrate as 4:1 or 3:1 ratio. The ketogenic diet is the treatment of choice for two distinct disorders of brain energy disorder: glucose transporter type 1 deficiency syndrome and pyruvate dehydrogenase deficiency. The ketogenic diet supplies ketones that bypass the metabolic defects and act as an alternative energy source in the brain. To describe the glucose transporter type 1 deficiency syndrome, it is a rare genetic condition affecting the brain metabolism caused by the mutations in the SLC2A1 gene. The phenotypic spectrum of glucose transporter type 1 deficiency syndrome is very wide and includes complex movement disorders characterized by ataxia, dystonia, and chorea. This may occur in combination or may be continuous or paroxysmal or continual with fluctuations in severity. The diagnosis of GLUT1 deficiency syndrome is established with suggestive clinical finding which happened in this case, normal blood glucose concentration, CSF glucose concentration less than 60 mg per deciliter, and the identification of pathogenic variant in SLC2A1 by molecular genetic testing. The causes of CSF hypoglycemia, that is decrease in glucose levels, range from inflammatory to inherited conditions and can provide a clue. The coordination between the pathologist and the clinician and the clinical correlation help to move in the right direction for diagnosis. The application of genomics help to confirm the diagnosis and the management. To summarize the whole case, a 12-year-old boy presented with cognitive deficits, myoclonus and dystonia of both upper limbs which falls within the spectrum of GLUT1 deficiency. The laboratory findings and the genomics help to confirm the diagnosis. Ketone bodies use a different transporter to cross the blood-brain barrier and thus provide brain with the only known alternative fuel for metabolism. Thus, ketogenic diet helps to improve the clinical condition of the patient. The coordination and the correlation of the clinical and laboratory findings helped in the right diagnosis of a rare disorder and the management. To cite few important references, 1. Alter et al. In long-term clinical course of GLUT1 deficiency syndrome in Journal of Child Neurology 2015. Second, DeVovo and Wang et al. Glucose transporter protein syndromes in International Review of Neurobiology 2002 and Ackman et al. Diagnosing glucose transporter type 1 deficiency at initial presentation facilitate early treatment. Thank you very much.